Good evening. My name is Tracy Norris, and I am president of APTA Acute Care. On behalf of our academy, I am honored to welcome you to this webinar, Acute Postpartum Rehab Toolkit for Moms. Thank you so much for joining us this evening. We are pleased to welcome Dr. Rebecca Seagraves, Dr. Catherine Sylvester, and Dr. Jenna Seagraves as our speaker for this session. We are excited to learn more from these talented presenters on the role of acute postpartum rehab, how to use a self-assessment tool with this population in order to monitor their vital signs and responses to activity, and learning how to explain these early rehab interventions and individual healthcare data that can improve maternal health outcomes. After the presentation, we will have a Q&A for additional questions and comments. During this presentation, if you have any questions or comments, please use the Q&A feature. Your certificates, the recording, and any handouts will become available to you 1 week after this session. I now have the great pleasure of introducing this evening's speakers. Dr. Rebecca Seagraves is a board-certified women's health clinical specialist and certified lymphedema therapist who has practiced with outpatient, home health, and in inpatient settings. She has served diverse populations in critical care, oncology, and inpatient obstetrics across 3 level 1 trauma centers. She has extensive experience with optimizing function in the high-risk pregnancy population during long-term hospitalizations and following prenatal loss. In the acute care and home health settings, Dr. Seagraves has worked with maternal care teams to maximize early recovery after delivery, including populations at risk for adverse cardiopulmonary events after cesarean delivery and obstetric critical care interventions. She is the founder of Enhanced Recovery After Delivery, an obstetrics clinical pathway that maximizes pregnancy and postpartum outcomes with occupational and physical therapy before and immediately after birth. Our presenter, Dr. Catherine Sylvester, is a mother of 2, physical therapist, preeclampsia survivor, and VBAC certified doula. She is the founder of Operation MIST, where she and her team daily and routinely monitor the health of women via a smart device and provide them with support, data, resources, advocacy, and education that they need to have a healthy pregnancy, catching issues early in between office visits, surviving delivery, and helping them recover without complications. And our final speaker this evening is Dr. Jenna Seagraves. Dr. Seagraves is a board-certified neurologic clinical specialist in physical therapy and a certified lymphedema therapist. She is an assistant professor in the School of Physical Therapy at Graceland University. Her clinical practice involves a wide variety of settings and populations, including outpatient orthopedics, outpatient neurology, lymphedema management, pelvic health, acute care with a focus on neuro and trauma diagnoses, critical care, the emergency department, and inpatient obstetrics. For the acute care obstetrics population, she evaluates and treats individuals within 24 hours following delivery. Please welcome our speakers.
Thank you so much. We are sincerely grateful to APTA Acute Care for hosting this exciting webinar and making it specifically for mothers. We are the respective owners of the content we are going to share with you tonight that has not been made easily accessible to moms. We want to acknowledge that. It's important to us that you know that the presentations like this are typically made about you and not with you. I've personally heard from doctors and rehab therapists that the information we will share with you is too overwhelming for you to hear when you're recovering after birth. The most logical response I had to this argument, the argument that we should limit rehab services or one-on-one recovery support in the hospitals after delivery or during the first week postpartum at home, was to actually go directly to moms. And also during the first week postpartum was to actually go and ask you for your opinion. What did you wish you would have known to improve your recovery after birth? What do you wish you would have known to have improved your ability to function, to bond with your baby earlier if you were in pain or exhausted, to be able to stand and take a hot shower without feeling like it took everything out of you? to feel like you had the energy you needed to care for your baby, to visit your little one in the NICU, or give your other children the attention that they needed. To feel like you knew exactly what you could do or shouldn't do early after birth. So it's been my personal mission as a health provider to not make decisions for anyone without asking for their input or for their permission. So through my company, Pelvic Health Network, I am honored to share the conversations that I had with 3 individuals, 2 mothers on the next slide, and a physician, about their perspective specifically on postpartum rehab and have their permission to share their voice. Their voice and their stories have helped us as a rehab team develop an assessment and treatment plan that we're planning to share with you all tonight, and hopefully have this treatment plan accessible to every mom who wants dedicated rehab services to help them recover earlier after birth. We have no excuse if mothers in the hospital want these services to offer them the resources earlier so that they can enhance their recovery. Tonight, what I would like you to do is listen to the stories of these moms, and we'll actually start with one who's a doctor of physical therapy herself, or a doctor of physical therapist, and also a mother who recovered from a first-time cesarean delivery. So we'll advance to the slides, and pardon our technical issues. This is what happens when you're presenting live, but we'll progress to the next slide. And what we'll do is we'll listen to Dr. Ann Crogan's story so that we can learn what it took for us to offer this webinar to you.
I'm Ann Crogan. I'm a doctorate in physical therapy. I specialize in public health and obstetrics. When I had my baby was breech, and I labored for a while before consenting to a cesarean. And so I had a cesarean birth with her. She was fine. I was not fine. My abdomen was in so much pain because of my major abdominal surgery. And I didn't have any sort of binder or anything to help support my abdomen. And I was sitting up in a bent position in the bed for a day before I went to go stand up. And as a physical therapist, we all know if somebody has a knee replacement, they should not have their knee in a bent position because they won't be able to get it straight. The same thing exists with the abdomen and scar tissue. So I knew better as a PT, but in that moment in time, I wasn't thinking clearly on that. So then when I went to go stand up, that scar tissue that had already started forming and a very large abdominal wound, it was incredibly painful without any abdominal support, like a binder or anything like that. I asked for physical therapy to come help me because I was a physical therapist and I know that physical therapists come to help people in the hospital. And the nursing staff snickered a little and told me that PT doesn't come here, meaning they don't come to the OB floor. And I said, why not? Because I can't walk. And they said, well, they just don't come here. I had a walker. After about 3 days when I could stand better because I had a reaction, I think, to the anesthesia that made my blood pressure continually drop so that I would faint. I did not leave that hospital room for about 3.5 days. And then the nursing staff gave me a walker, and I walked by myself with my husband and my baby, him holding the baby, down the hallway without having my vitals monitored as I walk. And I joke around with acute care PTs a lot, but they're really good at walking people. And I didn't even have them there to walk with me and make sure I did not fall. So it took me about a half an hour to even make it down the hallway and come back because I had to stop taking breaks, and because it was really painful, but I wanted to get out of that room. I, in that moment, knew that this wasn't going to work, and I was not the first person to experience this, and how sad it was that there were women out there that this was continually happening to. And I am a person who doesn't sit well with knowing that other people are suffering, so I wanted to figure out how to make it better.
There's never a dull moment when I really sit down and I go over the interviews that I have had the privilege of having now as a physical therapist, but then also more as someone who's just taking note of a bird's eye view. And I would really encourage you as a mom to really take a bird's eye view on your healthcare team. You're going to hear and see examples tonight that personally have just stayed with me throughout my whole career. Are these stories directly from your own community? Stories like Dr. Ann Krogan of what she just shared. And what I want you to get out of this is that had we not started to develop these assessments by asking questions of you, like what was your experience? How difficult was it to get out of bed without support? Because a lot of you often will hear this question or not hear this question. And that's kind of the problem, is that many times if you've delivered in a hospital, which over 98% of births are occurring, you're not asked about your bed at home. And the fact that she getting in and out of a hospital bed was really difficult after this major abdominal surgery, cesarean birth that she delivered by, that's one question that we felt what should be number one in our assessment. This perinatal function and mobility scale, we wanted the first question to just acknowledge, would your bed be similar to the one that you're in the hospital using? Does it go up and down? Does it have bed rails that allows you to pull up? Or if you're a single parent, which a lot of our moms were, would you be able to get up out of bed after a major abdominal surgery or maybe a large perineal laceration, or maybe from fatigue if you lost more blood than expected? Would you be able to do this by yourself, especially if you had to go to the bathroom or your baby needed you? Would you be able to do this? And so we developed this assessment based off a very well-known and well-used assessment called the AMPAC 6 clicks. Not that you need to know about that as a mom, but you do need to know that someone on your care team is asking these specific questions. Standing at least for 5 minutes, that could be in preparation for when you're making a meal or when you will be showering at home. Performing lower body dressing, that could be when you have to put your socks on, take them off, your underwear, your pants, doing all those things that we would take for granted. But definitely, if you are in the position that Dr. Ann Krogan was in, you would want someone on your team asking you those specific questions. And then whether or not you're able to actually care for yourself. The most important components, just realize, not just this assessment, but of your whole toolkit, your recovery plan, should be your team. Who are you surrounding about you at the time of your birth that's going to dive deep and ask the questions that we really need to know before we send you home to try to navigate this on your own? The next set of questions really have to deal with even higher level activity. So some of the moms that we worked with in the hospital had babies in the NICU. And so they might have been able to be wheeled down to the NICU in a wheelchair, but often if they were coming back and their baby was still admitted in the hospital and they were discharged home, they didn't have a wheelchair necessarily that was going to bring them down. They were dropped off via valet. And so they would have to walk a few minutes longer than they were even accustomed to in the first 24 to 48 hours while they were still recovering. And so that would be taxing for some moms to the extent that we would actually see them readmitted back to the hospital for things that we never want anyone to be readmitted back to the hospital for. Things like postpartum preeclampsia, maybe infection where internal wounds opened up and their doctors weren't aware of it, and then it turned into a very serious condition. And then hypertensive disorders, not necessarily preeclampsia, but things might have been related to blood clots. So walking while carrying an object that could have been their baby, had we assessed that using this simple assessment that we want all of you to have, we would have been in a better position to really catch those incidences before those moms returned to the hospital, and moms would have had a say in their care. They would have known that someone on their care team was asking their questions and also helping them create a birth plan that included their recovery. So we're going to hear from another provider about a treatment plan that we made specifically based on the story that you heard from Dr. Ann Krogan. But it's important, again, that you have someone like this on your team that's looking at everything, not just looking at the fact that you delivered a healthy baby and you're good to go. So we're going to actually hear from Dr. Karen Fox, who's a physician and a surgeon, who was so dead set on her patients having occupational and physical therapy that she offered those services automatically as a standard of care.
My name is Karen Fox, and I'm a maternal fetal medicine specialist. We all know that we as doctors are getting a little bit more, I don't want to say burden, that's not the word, but we are trying to take care of more people with the same resources that we have. And there's also a real push, both from a financial standpoint, from a patient satisfaction standpoint, from a infection control standpoint, to let people go home as soon as possible. We don't want to keep people in the hospital if they don't really need to be there, but we do want them healthy. And so by using our team members to the best of their ability, if I can have a physical therapist or an occupational therapist who's the expert in movement and doing those activities of daily living, meet with a patient one or two times, assess and give some recommendations, that frees up the nurse who otherwise might be the one who is trying to get the patient out of bed. If it reduces a fall because they're moving properly, that's time saved. It's an investment. And then that helps me as the doctor also. I spend a lot of time talking to my patients anyway, but if it frees me up to be in the OR and do that surgery and work to the best of my ability, then it just helps the team and importantly helps the patient and her family.
Questions I most often get, especially for moms, is what if I don't have a doctor like Dr. Karen Fox, right? Who has a doctor like that who's going to anticipate that if you did have a major abdominal surgery at the time of your birth, or you lost more blood than expected, or you had a grade 2 or higher perineal tear where you tore vaginally, that she's going to be looking at those other team members that you might benefit from, like an occupational therapist and a physical therapist. It was her that actually developed the cesarean delivery rehab protocol that all of you will get no matter what. Someone knows this. Over 1.3 million women a year that undergo this surgery. Is the most common surgery performed in the United States that results in an inpatient stay. And someone knows a mom who's had a C-section. And this plan starts 24 to 48 hours after birth. It starts in the hospital. And so you'll receive a copy of this tonight just for attending this webinar. This is free and accessible to the public anyway, but then you'll also receive the assessment that we want every mom to be equipped with. I want to leave you with this before Dr. Catherine really takes it away and just gives you those tangible things that we really want you to have before you even go into a hospital to give birth, or you have a home birth, or you choose to have a birth center birth, is that this plan, this treatment plan, really is not just for cesarean delivery, but it's really a snapshot for you to know that there is, and there are professionals who exist who offer these kind of treatment plans no matter what birth experience that you have. But it really is the responsibility on the mom to create her team before she gives birth. And we want to empower you with that. It shouldn't be overwhelming. If you're preparing for a successful birth, I want you to think of preparing for a successful recovery. And that's by having an assessment that your team uses to assess your function within the first 24 to 48 hours after birth, and also having a plan that starts within the first 24 to 48 hours after birth to enhance your recovery. Now I'm going to introduce Dr. Catherine Sylvester. It's a great honor to know her. She is the owner and the founder of Operation Mist, and it's been a pleasure speaking with you all tonight.
Thank you so much, Dr. C. Graves. It was wonderful hearing you as always, and thank you for the introduction. So I am super excited to talk with you ladies because this monitoring numbers is what saved my life following delivery. And so as soon as I realized that I could use a blood pressure cuff, a smart watch, a pulse oximeter, a thermometer, and a tape measure and make sure that I was fine, wanted to make sure that other moms did that as well. And in doing so, There have been 70 issues caught between office visits since 2021 that women caught on their own with the help of us monitoring them remotely. And so that's what we want you to be able to do, catch a minor issue before it turns into a major complication. And we also want you, though, to be able to go through your day-to-day activities, making better decisions, more healthy and informed decisions, so that you don't run into the major complications that are plaguing us here in the US. And so this is a lovely mom who was using her vital signs in the hospital. So when we started, I didn't think that we would be having to give as much support to people in the hospital. To be honest, I thought that it was going to be the people who were already at home and just kind of overdoing it because we're so in love with our newborns and our families. But what we found through this woman's story is that you can have low blood pressure, a high heart rate. You don't look quite right. You can't get up and walk, and you're still being asked to sign discharge papers. But because we were able to see her data and she had access to her data, she stood up for herself. And when they finally looked into it, she had lost so much blood that she needed a transfusion, but she lived. And now she's thriving. We've heard stories where it was not the case, where someone, they were losing blood and they were ignored for so long that they lost their lives. We're not going to let that happen. And what we found is that giving you all the tools, like Dr. Seagrave said, is the answer. You're with yourself 24/7. You know yourself better than anybody else. So you'll be able to advocate for yourself if given all of the information. And so 5 of the top causes of women dying from home or dying after delivery are heart problems, infection, losing too much blood, which they also call hemorrhage, blood clots, and high blood pressure. The tools that I told you that you should have are there on the left, and I hope you'll look back and just purchase them. All of them together are less than $200. And if you take off the smartwatch, it's less than $100. And so we're going to go through and talk about those major issues to catch. But also, I want you to think about how if you notice that your heart rate is going up when you shower, then you can advocate for yourself and say, hey, maybe I need a shower chair. If you notice that when you eat out, that your blood pressure goes up, then you can ask people, be empowered to ask people to bring you healthy meals so that you can eat better. Because the way to not run into issues is to figure out what causes my numbers to be abnormal. And once you do that, if you notice that you wake up in the morning and your stress is high and you have the opportunity to work remotely, that's the day that you'll call in and say, hey, instead of driving into the office, I'm just going to work from home. That's how we stop ourselves from running into issues day to day. And so in general, I have this list so that as a woman, if you are preparing for pregnancy, if you know someone who is throughout pregnancy, that's the general guidance. And when you look in the research, that's essentially what you're going to see. These are things that you can do to be healthy. After delivery, though, what we have found is that if women would stay between 3,000 and 5,000 steps a day, that's when you're going to be right where you need to be so that your heart rate doesn't get up too high, your blood pressure doesn't get up too high, and you're not overtaxing yourself. When we have people who walk more than that, maybe because they're taking a younger child to daycare or they're running errands for their family or they're single moms, the steps go up and then their blood pressure goes up, and it's very hard for it to come back down because within the first month following delivery, our blood pressure management system isn't quite right. Okay. It's a little bit different than it was before we got pregnant. And so we have to give our bodies time to settle back down. And so when blood pressure goes up normally, it can come right back down. But if after delivery, what we find is that when blood pressure spikes, and it's expected to spike between 3 and 6 days following delivery on average, it has a harder time coming down if someone's super active. Now, the other thing is getting at least 5 hours of sleep per night. So even though 7 to 9 is ideal, what we're seeing is that after delivery, if you can at least get 5, then you can keep those numbers under control. And then that's also what research says is good for your organ health and your organ function, because our kidneys, our heart, our lungs, all of that is working all day long when we're awake. So we need to give it a break when we're sleeping, okay? I hear sometimes moms say, you know, the only time that my vitals look good is when I'm resting like the entire day and I don't feel productive. Well, I want you to know that if you are raising a newborn, You are productive. You don't have to prove anything to anybody, including yourself. You're doing more than enough. And so all you have to do is take care of yourself so you can be here to care for that newborn. And then also make sure that you're checking your blood pressure once in the morning and once at night, at least for the first month, and then ask for help. If you don't know who to call, then call one of us and we will find you some help, okay? In terms of sleep, with good quality sleep, your heart rate goes down, blood pressure goes down, your organs rest, and your hormones balance. That is exactly what you need following delivery. When you look at that graph and you see the red and the blue, you notice that when you're awake, the red and the blue are higher. When you're asleep, they're lower. That's exactly what happens during sleep when we get enough of it. And so in the case that you're not sleeping for 7 to 9 hours, what you want to do is avoid screens 30 minutes before you go to bed, avoid eating large meals 2 hours before bed. Have a routine. Sometimes people are like, I don't have time for a routine. My routine is putting on my eye mask and that's it. As soon as I pull it down, it's that something in my brain says, okay, it's time to go to sleep. And so it doesn't have to be anything long and extensive. It's just doing something to let your body know that it's time to rest. And then also try to be active throughout the day. So what that normally looks like for a woman after delivery is we would like you to eat, let's say, and then walk for 5 minutes. And you're going to eat at least 3 times a day, please. A lot of times we notice that women, they're breastfeeding and they're doing other things and they just lose track of time. But if you make a 5-minute walk every time after you eat and then you're walking to and from the bathroom, you're going to be up enough to make sure that at night you're tired and ready to go to bed. Now, blood pressure, what you will hear is normal is less than 120 over less than 80. What I'll tell you is that my baseline was 100 over 60, and my midwife caught my preeclampsia when it was 128 over 78. And so that's why it's important to have your own norms. I'm sharing these numbers though, because when you look at elevated blood pressure after delivery, 140 over 90 is an immediate call to your provider. 160 over 110 is an immediate visit to the ER. We have to make sure that if our blood pressure spikes, that we get it looked into before it becomes a stroke or death. And so what we don't want to do is ignore the elevation and then it get critically high. And if you know your baseline, then I would tell you, if you see that you're sitting in the same exact spot where you always sit, your back is supported, feet are on the ground, your arm is at heart level, just like you see in this picture, you're not talking to anybody, nobody's talking to you, and your blood pressure is even 20 points higher on the top or 20 points lower or 10 points higher on the bottom, 10 points lower, I would still call your provider because you are trending in the wrong direction and they can help course correct. And so as remote monitors, of course, we're the ones doing the remote monitoring and the course correction and then letting people know if it's something they need to go in for, but also we can help them scan their day. And so if they haven't had any water or didn't sleep at least the 5 hours, they have a stressor that came up, then we're able to help them troubleshoot, check blood pressure again, and make sure that they're okay. And so what we want you to do is just make sure that you're checking and then reaching out to someone who is a healthcare provider who can help you make the next best decision. Because in general, your blood pressure should not change much, even if you go from laying to sitting to standing. Now, if you start exercising, it is expected that your blood pressure is going to go up, and that's because your body needs more blood flow, it needs more oxygen. And so when Dr. Seagrave was talking about showering, when I said exercise, and so a lot of people are thinking, well, I wouldn't be exercising right after delivery. We'll tell you, I met some women at 2 weeks who are like, I'm ready to go and get out to run. And the thing that stopped them was that they noticed that when they were even walking around their house, walking up and down the stairs, their heart rate went up as if they were exercising and it did not come down by 18 beats in 1 minute. And that's why it's so important to have a pulse oximeter that can check your heart rate right then, or have a smartwatch where you can look at your heart rate right then. And a minute after exercise, if you notice that you're at 120, from walking up and down the stairs, after a minute, if you're not at 102, that's too much activity. And so that can help slow us down. But the other thing is that showering, if you look at how much energy has to be expended, is on the same level as cycling, which you would not do following delivery. But all of us are looking forward to our showers. And so we have to see, what is showering doing to my heart rate? And is my heart rate actually coming down appropriately? Same thing with blood pressure. Within 5 to 6 minutes, blood pressure should come down after stopping exercise. If it does not, that's too much. Okay. And so even when you're in the hospital, if people are checking your blood pressure at rest, because we hear it all the time, they say, oh, their blood pressure is fine. That's because you've been laying down for 3 days. We need to see what is your blood pressure when you're up and walking around after you've done the stairs, when you're managing your baby. And if they're not taking it, you need to request it because you deserve to know your numbers before you go home and have the support that you need. Now, if your blood pressure is elevated, don't worry about it. We always tell people it's not about catching issues, it's about missing issues. Because if we catch high blood pressure that's severely high, Lasix plus potassium is like a game changer. We had a mom, she caught her high blood pressure at day 19 post-delivery. So I know I told you that it spikes typically between days 3 and 6, but what we're finding with women post C-section is that it's spiking later. And we've had, even just today, we had a woman, she's 11 days post-delivery, and her blood pressure spiked 11 days post. And so we got to keep checking, okay? But if it's only moderately elevated and it's not lifestyle related, then you're able to take oral medication. And what cardiologists say and the research says is that if you do that and you get your blood pressure under control, now it helps you avoid issues later. And so we also have to consider, though, pain, any type of fluid that you received, any swelling that you're retaining. If you're on any of the pain medications listed like aspirin, Motrin, Advil, ibuprofen, Aleve, those can all also impact your blood pressure and also your blood vessels going back to how they were before you got pregnant. So normally during pregnancy, your blood vessels are relaxed, and so more blood is able to flow through without raising your blood pressure. Blood pressure actually goes down, as you see in this graph, during pregnancy, and only returns back to baseline around the end of your pregnancy and should stay there following delivery. But what happens sometimes if we're swelling is that those blood vessels that were nice and relaxed, they go back to being the way they were before, and there's still a bunch of blood flowing through it. So blood pressure can go up. So if you've had a C-section delivery, if you've had a lot of fluids, then make sure that you're watching your blood pressure even closer. Because every spike is not preeclampsia, but sometimes it is. And so you have to be able to tell the difference and just kind of give the information that you know is needed to a healthcare provider when you reach out to them. And so preeclampsia, for you to detect it in your home, if you have a rise in blood pressure, which we already talked about, that's a sign, but also foamy urine. So if you use the bathroom and you look inside, you should typically see a light yellow color. If you see bubbles, like there's a bubble bath, that lets you know that you could be having preeclampsia going on. That's what happened with me. And when I tell you, I was so happy to see those bubbles going away as my blood pressure started resolving. It was a blessing. But seeing it is a red flag. Severe headaches, changes in your vision, whether it's floaters, blurred vision, light sensitivity, a temporary loss of vision. For me, it was a loss of peripheral vision. All I could see it would seem like I had tunnel vision, and it only resolved when my blood pressure got under control. You also may have a decrease in urine output that lets you know your kidneys might be affected, shortness of breath, and then sudden weight gain and swelling. After delivery, no one wants to be told you still look like you're pregnant, and yet some people are, and it's typically because of their stomach. But if you notice that your face stays swollen, your hands are swollen, the swelling in your feet is not going away, that's a reason to reach out to your provider, okay? The next thing that we can catch from home or after delivery is blood loss and hemorrhage. And so during a vaginal delivery, you typically lose a half a liter. During a C-section, you lose 1 liter. But at 0.75 liters of blood loss, signs start showing. And so you should put yourself on high risk for a hemorrhage if you've had a C-section. Not that you're looking for something to go wrong, but you know that you're at a little bit of a higher risk because you've already lost more blood than what would be expected to lose. Your symptoms will show up if you've lost at least a liter, and you will have after a cesarean delivery, because you typically start seeing those signs at 0.75 liters. And so if you had multiples, twins, triplets, or you had a rupture in your uterus, if your placenta separated from your womb before you delivered, or if you had too much amniotic fluid, those are also things that place you at a higher risk. So just go ahead and pay more attention to yourself and make sure that your providers do too. Some signs that you may have lost too much blood from a vital sign perspective is a drop in pressure to 85/45. Now, the mom that I talked about at the beginning, her blood pressure was 90/60. And so remember, it's a relative change in your norms. So this is not absolute, but it is a really, really good guide. If you are sitting still and you check your heart rate and you're at 110 beats per minute, or if you put the pulse ox on your finger and you're at less than 95%, those are all signs of hemorrhage. Other things to feel for are dizziness, look for bright red bleeding, especially bleeding where you're soaking more than one pad in an hour. But what you should also do, not all settings do a post-delivery hemoglobin check, but in the hospital, they typically do. We've had women where it has not been checked and they've asked for it because 1 liter of blood loss, 1 gram per deciliter of blood loss is normal. So if you had an 11 going in and you leave with a 10, that is considered normal. If you had an 11 going in and you leave with a 9, then that lets you know that you could be losing too much blood. The good thing is if you've had a C-section and you're there for an extra day, then you ask for another hemoglobin check. That way, if you go down to 8, then you know that something is going wrong, right? Because you're continuing to lose blood. You should expect your blood to stay where it is, not to continue to decrease. So even if you're at an 8, and the hospital doesn't think of an 8 as critical, because a lot of times they won't give you blood unless you're under a 6. You need to advocate for yourself to stay longer so that you can be investigated. And also so that you can know, how do I need to modify my activity now that my body's not getting the oxygen and blood flow that it needs, simply because it doesn't have enough blood flowing through my system. And so looking at those numbers is really important, and understanding that it can occur up to 12 weeks following delivery. So when you leave, continue to monitor yourself for these signs. Heart failure is another thing that can be missed, and it's because sometimes women go to the emergency room and they tell them, I'm having shortness of breath, I'm having chest pain, I'm really, really tired. And they are told, you just delivered a baby. Of course you're tired. This is how things are missed. In 48% of cases, diagnosis is delayed by more than a week. And then in 30% of cases, they're delayed by several weeks. And we've had women who are put on mechanical hearts. They were in heart failure and being ignored. This will not be you, because if your blood pressure is below 90/60 and you have those other signs, or you just feel like something's not quite right, then ask for these labs to be drawn: troponin, BNP, N-terminal BNP, and your ejection fraction to be checked. Because if you notice that any of these numbers are off, a cardiologist will be right on top of it. But if they don't check for it, they don't know that it's happening. So one of our moms, she caught her heart failure. She was 5 days post-delivery, and her cardiologist told her that she had 2 weeks. If she had stayed home for 2 weeks, she would not have made it. And so we want to make sure that we're not ignoring the symptoms when we see them. In terms of infection, if infection is caught early, it does not turn into something called sepsis. Sepsis is when your organs start to fail and you could die because the infection has taken over your entire body. So what we want to do is make sure that we're looking. If our top number gets to below 90 with our blood pressure, if we notice that we're breathing really fast and we stop to count and we're breathing more than 25 times in 1 minute, or we just start to feel confused, and then we check our temperature, we're at 100.4, go ahead and go to the ER. You need to be checked out. And that way your infection can be addressed. Some other things: dizziness, increased bleeding, confusion, or slurred speech. If you have pale or light complexion, pale skin on a light complexion, or light patches of skin on darker complexions, then that lets you know that you could be having an infection and you need to go to the hospital right away. The last thing that you can catch from home here that we'll talk about today is blood clots that travel to your lungs. So with this scale, it's called Wells criteria. If you score at least a 4, then that lets you know that your blood clot could be blocking an artery in the lungs, and the body cannot survive without oxygen. And that's what the lungs are supposed to be doing to the blood that's flowing into it. And so if the blood is not able to get there, then that means your body will not be able to have oxygen, and we cannot survive that way for long. And so if you have a tape measure and you measure around your calf, because sometimes the swelling looks exactly the same to the naked eye, but once you measure it, if it's greater than 3 centimeters compared to the other leg, it's possible that you have a blood clot in it. And then if you pair that with at least one other thing on this list, that's an immediate call to your provider. So if you had a C-section, you had to be on bed rest before you delivered your sweet baby, if you're coughing up blood, if you have cancer, if you're sitting, you check your heart rate and you're at 100 beats per minute, then you know that you need to go ahead and call in. One time a mom called in and it turned out that she just needed LASIK. So she did not have a blood clot, but because she alerted her providers, they looked into it and did give her what she needed. And so some signs that a blood clot is blocking blood flow to your lungs, you will feel it right away, but your heart will beat really, really fast. You'll start sweating. You start feeling anxiety. And then as you increase your breathing rate, because the body is really trying to get in oxygen, you will start feeling chest pain that gets worse with every breath. Immediate visit to the ER. Okay. And then mode of delivery matters. For people who delivered via C-section, what research shows in this study, there were over 1 million women included, is that people who had C-sections had more than double the risk of having a heart-related issue within the first 42 days following delivery. And so that is why I am so passionate about people not having unnecessary cesarean deliveries, and you should be too, because you all know someone who's going to have a baby who is pregnant, and they do not need to undergo surgery if it's not necessary. And so the 4 things that were looked at in this study were blood clots that move to the lungs, a stroke, and a heart attack. And if we know we're at a higher risk, then we just have to watch a little bit more closely. And I know that Dr. Seagraves talked about us being on the team, and I think it's so critical that physical and occupational therapists are on the list like us. But also, if someone's had preeclampsia, having a kidney doctor or a cardiologist on their team is important. If they're having breathing issues, a pulmonologist or a respiratory therapist. So this is just a list for you to look over so that if someone does not give you the teammate that you need, you recruit them yourself. Thank you so much for your time, Dr. Seagraves. I will turn it over to you, ma'am.
Thank you so much, Dr. Sylvester. My name is Jenna Seagraves, and I'm honored to share this space with all of you and to discuss a few critical things that you can do in your first week after any birth experience. So first and foremost, one of the most important things that you can do to enhance your recovery after birth is to request for a postpartum visit from an occupational or physical therapist while you're still in the hospital, or even make it known that you would like rehab services after you give birth while you're still pregnant. Rehab therapists are experts at making sure that each activity, exercise, or recommendation is tailored to you. Now, I'm going to walk you through some of the most common exercises or recommendations that are given to postpartum individuals following various deliveries or those with different postpartum issues. The first exercise, as you can see here, is called the long body stretch. Now, this stretch is often recommended for someone who has had a cesarean birth, someone who has upper back pain, or someone with diastasis recti. That's also called it's a separation of your abdominal muscles. This exercise, as simple as it may appear, can be so relaxing and pain relieving. Having your arms over your head allows your rib cage to expand better, which can help with taking a deeper, more controlled breath. It also allows the body to truly stretch and prevents excessive scar tissue or swelling following a cesarean birth. The next exercise is the cat-cow. Now, this exercise is commonly prescribed to those who have sustained a perineal tear, those who have pelvic pain, or those who have suffered a tailbone injury during or immediately after birth. This gentle exercise allows you to reconnect your breath with your movement, and it also provides much needed flexibility to your spine, which likely has not been able to move like this for quite some time. The images in the bottom left corner of each picture is simply a guide to help remind you to coordinate each movement with your breath. For example, the image on the left is showing the cow pose with a reminder to breathe in. The image on the right is showing the cat pose. Notice that it looks like a frightened cat with its back arched, with a reminder to breathe out as you move into this position. This slide is demonstrating a mobility recommendation when getting in and out of bed, called the log roll technique. This way of moving is recommended following a cesarean birth to reduce the strain along the incision. It's also recommended for those who had a perineal tear during a vaginal birth to reduce any pain or strain along the perineal muscles. For someone who has had a tailbone injury, this way of moving allows your spine and pelvis to move as one unit and avoids any twisting, which will help alleviate some of that low back pain. The 3 images from left to right are demonstrating the technique, with the first image showing that the knees are bent. Now, what I want you to do is remember this slogan: exhale on exertion. What this means is to breathe out as you do any transitional task. So in this case, after you have bent your knees, take a deep breath in, then breathe out as you turn your body as one unit onto your side. I like to think about moving my shoulders and my hips at the same time to make sure that my back does not twist. Then in the third image that you can see, bring your legs over the edge of the bed, take a breath in, and breathe out as you push through your arms to come into a sitting position. It's important to remember to push through your arms rather than having someone pull you up. Being pulled through your arms will actually increase the work of your abdominals or your back muscles, and it will place increased strain on your incision if you had a cesarean birth. This slide is demonstrating more mobility recommendations really for any delivery type to help support the back and the legs, which we often prescribe in the hospital within 24 to 48 hours after a cesarean or vaginal delivery. These exercises help restore posture and strength without straining a cesarean or a perineal incision. The first image on the left is a modified downward dog, which provides significant comfort and stretch to both the lower and the upper back, which can be relieving to anyone following the strain of pregnancy, as well as the task of delivery. The calf raises on the right help to improve blood flow in the legs, especially when swelling continues after birth. These exercises are examples of what we have provided our clients and patients with, and we highly recommend that you have a rehab or postpartum recovery specialist on your team who's familiar with your unique birth experience and who can design a specific postpartum recovery plan for you. Here are some examples of postpartum support garments that may be appropriate for you. An abdominal binder can be so beneficial for those who have had a cesarean birth because it provides support and mild compression, which will reduce pain and actually improve the overall healing process. There are also compression briefs or spandex that can be helpful following a perineal tear. It's important to consult with a rehab specialist to ensure that the support garment is appropriate for you and that you're provided with a prescription as to maybe how long to actually wear it. Request a postpartum visit with an obstetric physical or occupational therapist after you deliver to enhance your postpartum recovery. So let's take a few moments here to hear directly from a mother's experience of receiving postpartum physical therapy care.
My name is Heather Battaglia, and I have a 7-month-old daughter. It was a C-section that was sort of unexpected. Had I not received physical therapy in the hospital, I would have been a lot more cautious with movement. It would have taken me much longer to feel comfortable lifting my baby, sitting down even. The nurses were not really able to help me figure out how to go from sitting in the hospital bed to standing up and back in a way that was not painful. And physical therapy, when she showed up, she said, no, here are some techniques you can use to make this work for you. Had I not had physical therapy, I just would have been wondering, is this supposed to hurt this way? Am I doing something wrong? Am I doing something that's going to jeopardize how I recover? I was surprised at how much physical therapy helped because I think I had some ideas about how physical therapy was for moms who had given vaginal birth, moms who really needed to heal their pelvic floor. And I wasn't sure how physical therapy could help me as the recipient of a C-section. And I was amazed at how much it helped. So I think what I would say to a mom who is getting a C-section is just because you didn't give birth vaginally or you don't feel like you have leakage or pain, doesn't mean that physical therapy can't help you recover better and faster and be more confident in your body.
I hope these videos have been as powerful for all of you as they have been for all of us. Here are some additional resources as well as references that were used during this presentation. So you can see them listed here. Thank you all so much for your time. It was a privilege to speak on this topic to you, and we'd like to open the floor for any questions at this time.
I just want to thank all of you for your presentation. I know I learned a lot in your session. There's a lot I'm going to bring forward to my practice. This does seem to be a population that maybe we didn't learn much about in PT school in terms of all that we could do with this population. So really appreciate the creation of this toolbox. We have a lot of great questions in the Q&A box. I'll start with the first one. Do you recommend TENS after C-section acute care setting for the C-section pain or for any other musculoskeletal pain?
Rebecca, would you like to take that one?
Yeah, sure. I personally have never used TENS in the acute care environment, but if it helps with pain, I don't see a reason why you wouldn't use it. And some moms are so savvy and they're bringing their own devices into the hospital, which I mean, Dr. Sylvester probably, would encourage moms to do. So if this is something definitely during pregnancy that you use along your back, not on the uterus, of course, or near the incision, but anywhere just around the posterior, the back, or pelvic girdle, if that helps you and that's comforting to you, please use it and get guidance from someone who would actually know how to guide you. And so if your acute care therapist who shows up in your hospital room is just not familiar with that device, just make sure that you do have someone on your team that you've been seeing during your pregnancy that can guide you, especially even virtually, if you're getting that kind of care at home, which I would recommend every mom really teams up with a care provider who can provide both virtual care as well as in-person care. Great question.
Continuing our questions, one question is about TENS again. Can you share TENS parameters during labor and few companies which you have used successfully?
I think I'll probably take this one again.
I was going to say, I'll leave it to the doulas here.
Yeah. In terms of just specifics, I probably would not be the best person to tell you for this Q&A. So no, I cannot, but it would be something I would probably research or consult with someone who's pretty familiar with those parameters for labor and delivery specifically.
Thank you. Next question. How did you advocate for regular PT orders from hospital OBGYN physicians?
I'm happy to take this one. So I wish it was just such a simple, quick answer. Here's exactly what you need to do this one thing. But one thing that I've done in the past that has been really helpful is to first really get the rehab team on board. So going to the manager and also making sure that you're not alone. So I did an in-service to other therapists to see those that might be interested, because to be completely honest, once OBGYNs hear about this, the floodgates open. And if it's just you as one person, it's extremely overwhelming. And if you can't get to all the patients, that actually looks worse, right? We want to get to all the orders that are then put in. So first I needed our management side to agree to this and get other therapists involved. And then I actually did in-services with the different members of the maternal care team. So physicians as well as the nurses and any of the advanced practice providers as well. So PAs and nurse practitioners. And so getting them on board as well can be so beneficial. But I would say make sure rehab is also on board before going to them first.
If I can just add one more thing to that, because this webinar is specific to moms, is that you're going to probably find that 98% of the hospitals do not offer rehab services, and you will be waiting a lifetime and your daughter's lifetime if you ever expected that to change. And so the biggest thing that you can do from a mom's perspective is really to advocate for yourself during your pregnancy, is to have your birth plan that is inclusive of your recovery plan, to basically say, this is what I want. If I'm in the hospital, this is the provider I want on my team to be speaking with me, and then seeking those providers out. And we have a list of hospitals that are providing OT and PT services, but in the cases where moms were not given rehab care, Dr. Sylvester and I have teamed up and advocated for moms for their birth experience and provided that care that they did not have access to. So really it's on the mom to advocate for yourself if your hospital just decides that they're not going to provide those services. And as you can see, our hunt has really been finding those moms to share their stories, to empower other moms to fight and advocate for themselves.
Thank you. Next question. Dr. Sylvester, the tools you mentioned, are they covered by insurance or FSA plans?
So I've noticed that the blood pressure cuffs are often covered, but the other things are not. So we send them to our moms, and as a physical therapist, if someone's doing a virtual visit, making sure that moms have them is really important. And then I'll also say there are some community-based organizations like Healthy Mothers, Healthy Babies. If someone is on here and they're in Georgia, they actually send all of those things, a thermometer, a blood pressure cuff. And there's a third thing. I think that they might not have the pulse oximeters in there, but they're all able to be purchased from Walmart. And so what we tell moms is, when you make your baby shower list, put those things on the list, because people want to give you things that will save your life.
That's an excellent suggestion to add it to the baby shower list. Next question, how long should the postpartum period of activity modification be? The sleeping 5 hours and walking 5,000 to 7,000 steps.
So it has to be that the person is looking at that they're looking at their data, or someone else is looking at their data to be able to help. The reason I put the 3 to 5 is because we've monitored about 150 women at this point, and we just noticed that that's the sweet spot. But the time frame depends. Most of the time, I would not even say most of the time. The time frame depends. And so there are some people who recover faster than others, who their blood pressures don't spike. But I would say that at least for the first 6 weeks, we should be focused on caring for ourselves and taking it easy, even to the point where we're pushing out or requesting remote visits. Because like Dr. Seagraves, both of them have said, it is important that you have people on your team who can support you virtually, because if you wake up and your blood pressure happens to be 150/90 and you are on blood pressure medication, that is not a time that you need to go do a newborn baby visit. And so we've had moms to actually push that out, or have pediatricians come to them, and it's been super helpful. So I cannot give an exact time frame, but I can say that if people are monitoring themselves, then they know when they're able to increase their activity levels.
Great, thank you. What kind of resources and tips do you have for expanding PT services and dealing with pushback from providers?
I'm going to take it that this is not a mom asking this, but I would say for the mom, you have you hold all the cards. I can't express this enough. If you want someone on your birth team, most chances your OB is going to advocate for you. And that's I just have to put it right back to the mom, is that if you're a PT who works in a hospital and you have not spoken to a mom, and I know, Dr. Seagraves, Dr. Jenna Seagraves, and I will probably disagree on this, because she does go to the rehab team, and I advocate to that, a certain extent as well. But if you have not spoken to a mom, just listen to the stories that we shared today. Like if you've not actually taken into account like what they want and what they would wish that they would have known or even been in Facebook groups and you're trying to start this program, you're really at a disadvantage. You know, you're not really advocating on behalf of them because you haven't heard their story. And so I would say, you know, really include the mom's experience, have some time on the birth unit yourself, try to get, you know, screening time or like Dr. Sylvester, she was an acute care therapist that would go onto the maternity unit on her own time, right? And just observe. And I would say build those relationships first with those patients if you're able to in your community, but then also with the providers who work on those maternity units and just understand their perspective. And then they'll be asking for you to come. You know, if you're getting pushback, there's a piece missing. And I think it's big for us to say this openly and publicly, that is communication. A lack of communication is what's causing moms to be harmed.
And I'll actually add to that too. So if, let's say, for example, it's a mom that wants rehab, but they're the ones getting pushback from the physician. And we've actually encountered this too, where some physicians will say, no, I don't think you need it. So if that ever happens, I would focus on, well, what is it that you're currently having trouble with, right? So you could say things like, well, I have a flat bed at home and no one's taught me how to get in and out of that without using the rails. Or the head of my bed in this hospital room is always up. I don't know what I'm going to do when I go home. I'm in a lot of pain. I'm in a lot of discomfort, and I don't want to be taking a lot of pain medications when I return home. How will I manage this without the medications I'm currently on here in the hospital? So being aware of what therapy or rehab services can offer can help you in advocating for yourself to get them in the room to see you.
Thank you. It is just a little bit after 8, and we have several more questions. So we'll keep going with a few more questions here for everybody that's able to stay with us. Bobby, did you want to continue on?
Yes, thank you, Noel. Do you recommend the use of TED hose after normal or CS delivery automatically, or more of like a case-to-case basis to prevent swelling or possible DVT?
I personally do not like TED hose, but I'll let Dr. Sylvester take this one. If someone is moving, it's not an automatic for me. If anyone has worked with TED hose, they're extremely hard to get on. And I just want you to imagine from the standpoint of a single mom who's not even told how to get them on and off and told that she has to wear them. And then they pinch and start to tourniquet and could actually cause an issue with poor circulation to the rest of her body. I've seen TED hose used in cases where those individuals may have twins by cesarean delivery and they're not moving very well, completely necessary because they need that stronger compression. But if we're able to get the mom up, if they're able to do calf raises or walk around or just be mobile, or if there's some type of sock that they have more control over putting on that has compression, definitely like those versus the TED hose, which are very thin. They tend to tourniquet and roll. But I'll let Dr. Sylvester take this one because I know she was just about to answer.
I love that you said that because we just had a mom and it was exactly what you said. By the time we saw her, her legs looked like elephants. And so, an automatic order, no, but I do think that people should have ready access to them if they need it. And the problem is if we wait until after they're swollen to get it, then sometimes it ends up delaying a problem that could have been prevented. During pregnancy, I have seen that for people who walk, and I know we're talking about post-delivery, that walk around a lot or they swell a lot. I've noticed that that is really helpful in helping to manage their swelling. But post-delivery, it is more what Dr. Seagrave said, which is just helping them learn how to move without pain. Because with this woman that I just mentioned, I walked into her home, her blood pressure was in the 150s over 90s. And after about 30 minutes of finding a comfortable place for her to sit, 7 pillows, 2 ottomans, ankle pumps, massage, her blood pressure was down in the 120s over 70s. And she was literally in tears. It was the first day in 10 days that she was able to sit. And so when people tell you as a mom, you need to relax, you need to sit down, you have to communicate back. I don't have a place that's comfortable in my house to sit, so I'm literally standing up all day. And to you, that's respite to your body. That is a marathon. And so I think that if the compression hose are needed, then we just have to make sure that moms can get them faster.
That's a one interesting information. I said, think about that. Following the questions, can you do cat-cow exercises on patients with unexpected C-section with perineal pain or pelvic pain? And how soon can you start the cat-cow exercises after C-section?
So generally speaking, the cat cow is not something that I have typically prescribed after someone immediately after someone's had a cesarean section. It can be rather uncomfortable actually to kind of get onto all fours and then to move through those transitions. So a lot of times that's an exercise given for those that have either tailbone pain or they've had a perineal tear specifically. When we take into account that abdominal incision, that's just me personally. I don't know if the other two have differing viewpoints on that. And then in terms of when is it safe, I would say once the incision has closed and healed, then I would feel much more comfortable with that. But I would like to hear if the other two disagree with anything.
No, not disagree, but definitely on those slides, we specifically put those conditions, and Dr. Jenna Seagraves is absolutely right. So a cesarean delivery, you also have to take into account that that mom could have gotten a nerve block to her abdominal region and also is on narcotics. You know, that maybe a mom after another type of delivery type might not be on stronger medication. And so it could almost be a little kind of a false security to try to get into bed if they're not feeling that pain, because we've treated moms who were readmitted back to the hospital for cesarean incisions that have split open. And so all those exercises that she went over, they can be done within the first 24 to 48 hours in the hospital after birth, but really looking at those specific delivery types. That's why as a therapist, if you're asking this question, you really have to know your prescriptions and your exercise prescriptions for, major abdominal surgery, like a C-section versus a perineal laceration. But if you're a mom, you want someone on your team who has that knowledge. So they can't just throw exercises at you for another delivery type because it could really damage your healing. It can really slow your healing. But in terms of just the perineal, the tailbone pain, all of that can be done pretty soon. And we even have an example of there where Jenna was showing like a downward facing dog, something on a counter or on a wall so that you're not having to get into those all four positions if that's uncomfortable after a perineal laceration or perineal tear, which you can start to move your spine and just move that tissue so that it's not healing in a flex position. Because I've seen some moms in their hospital bed who were in a fetal position because they were just hurting so much and they weren't allowing that tissue to move and stretch. So really, it depends on your therapist having that, having that skill set. And that's why we encourage you to really find that person on your team while you're still pregnant, hopefully, or someone who's been trained to provide these services early after birth.
Yeah, and I was just going to add that after your incision is healed, you would be, prior to that, if you have a therapist, they will already be teaching you to recruit some of your core muscles gently, right? And so once you get into that position that you need to be in for cat-cow, someone would be there to look and see, do you have core control to keep your organs in place, or how are you pudging, or what's the word, doming? When you're doing that position. And if you are, then it's too soon. So if you're by yourself and you're trying to get back into those type of exercises, making sure that your core is doing what it's supposed to do, which is pulling in when you get into that position, not doming out, is really important. And if you notice that it domes, walk away from that exercise for now, try back again in 2 weeks or so and see what happens.
Thank you very much. Now I pass this to Noelle.
Thank you. What kind of research have you found, or any results you've found on your own regarding these interventions being used with high-risk pregnancy and moms who are admitted to the hospital for prolonged periods of time?
I think so much of the work that we're doing right now is driven by the fact that there is a lack of research. So our own experiences, especially Dr. Jenna Seagraves and myself, we have worked on the high-risk pregnancy unit with moms. And so we had to do trial by fire a lot of times and work with their MFM, their maternal fetal medicine physician. and work through exercises that we weren't really sure, is this going to actually cause, because, to be fair, what Dr. Sylvester covered is so important for moms to take away from is that their own data, there's just nothing like it. There's no comparison for it. And it's so hard to generalize exercises for a whole group of people when preeclampsia is very specific to that individual and their organ function, or gestational hypertension, or some other issue that they might be dealing with. So maybe their fetus, their infant before birth is actually sick. And so we are constantly testing with high-risk pregnancy if these interventions will help to keep them active, to slow deterioration, to slow muscle loss, because not being active during their pregnancy is as harmful as doing too much. And so it's a constant balance, and no research has been done on providing these rehab interventions during pregnancy. We really have to use the data of that individual and have their whole team on board so that they're monitoring their response to activity.
I love that, because in a woman where we caught her preeclampsia at 34 weeks, she was asked to have a C-section at 36 weeks, and we were able to keep her pregnant until 39 weeks. And when she was told she needed to be on bed rest, we were like, can we just watch her stress levels and watch her numbers, see what her blood pressure does when she walks a certain distance? And so for this mom, 1,500 steps was the upper limit. And so we found that out. So she didn't have to be in the bed in the hospital the entire time. She was able to walk at least 1,500 steps a day leading up to the marathon that is delivery. And so we've worked with a lot of high-risk moms. The funny thing is, when people send them to us, they send us high-risk people. But I always try to remind people it's easy to go from low risk to high risk. So it's important that every person monitor themselves, because pregnancy, ladies, it's your heart is working 50% harder. Your kidneys are working 50% harder. And so we have to make an accommodation for that. And we have to know that even if research is out there, and there is research out there, that things can be different for you and how you respond to the to the pregnancy process. And then also taking into account what their health was prior to getting pregnant, because that also informs how they're going to go through a stressful event.
And because I know the question was asking a little bit about these exercises related to high-risk pregnancy. So I did just want to clarify, the exercises that we discussed during the presentation were more specific to postpartum, not to say that some of them can't still be done during pregnancy as well. But I do just want to clarify that depending on the high-risk pregnancy diagnosis, exercises will vary. And there's also a lot of others that we didn't even remotely cover, such as maintaining a lot of upper body strength with resistance to help prepare someone for birth and for the acts of things that will take place after birth, such as the long repetitive holding of the infant. And so it really depends on, is the high-risk pregnancy restricting you to bed rest only? Or do you still have, you're still able to do activity? What are those guidelines and restrictions? And then we tailor exercises to that. We as in rehab therapists.
Okay, we just have time for one more question. What recommendations do you have to increase buy-in for providers to use PT more in the acute setting, and recommendations for increasing therapist buy-in? So it's difficult sometimes to get therapists that are comfortable with this, and particularly therapists that don't have any certifications.
Who's going to start this one? I think we all have a lot of thoughts here. So if we're speaking to, let's say, it sounds like maybe this was a therapist asking this question and not so much a mom. But what I'll say, if let's say you're a therapist who is trying to get other therapists involved or interested, and you're not getting a lot of buy-in, a lot of ways that I've tried in the past is comparing it to other abdominal surgeries that most acute care therapists work with on a regular basis. So thinking about a cholecystectomy or a colectomy, any of these other just general abdominal procedures that we see pretty routinely in the hospital setting. Thinking about, okay, so what do we normally go over with them? This is now someone who's a lot younger, and even though there's a stigma that they're healthy and they're young, that they still had a major open abdominal surgery and they may or may not have the support at home. They not only do they have to recover from this surgery, but they now have another life to care for. They have all these new tasks ahead of them. They have additional ADLs that are going to be added to their regimen that include caring for this newborn as well. And so that's one avenue. Now, if you're a mom trying to get a therapist to buy in, and maybe this has happened, actually, we do have a close friend that advocated for therapy, and then therapy was like, I don't know what to do with you. And so we had to help we had to help our friend advocate for herself and sort of guide the therapist on what to do. And, well, I have a bed at home without rails and it's flat, and I need to know how to get in and out of this. Or, I've had a major surgery. Is there a binder that I could use to help reduce some of my pain? So that's something that I would say that a new mom could do to try to advocate for herself. Again, focus on what you're having trouble with or the questions that you have. Is it safe for me to do this? I have a lot of discomfort. As that video we watched, she had a lot of trouble just going from sitting to standing and then going to sit back down. Do you have trouble with that? Tell your therapist so that they know what to work on.
Excellent. Thanks so much for sharing. We do, on behalf of the APTA Acute Care Academy, want to thank our presenters for sharing their expertise and take-home messages for us. And I want to invite everyone to join us for upcoming acute care events. We have a town hall meeting on Monday, June 23rd. This will not be recorded, so make sure that you make plans to join us for that. We're also having a live webinar related to how PTs and PTAs can strengthen their interprofessional team in acute care. That will also not be recorded, so you'll want to make sure to make plans to attend that on June 30th. There is a small fee for that. You can register on the APTA website, and we look forward to seeing everyone soon. And thanks for joining us tonight. Have a wonderful evening.